Welcome, everyone. As you're joining, please post your introduction in the chat. My name is Jessica Farringer, and I'm the director of the Data for Impact project. Today's webinar is on a new set of tools, the Every Newborn Measurement Improvement for Newborn and Stillbirth Indicators tool set. Next. Before we start, I'd like to just say a little bit about Data for Impact for those who may be less familiar with the project. So Data for Impact, or D4I, is a USAID funded project, and we work to help generate strong evidence for program and policy decision making, also strengthen individual and organizational capacity for data related work, and to enhance the use of data for global health programs and policies around the world. And if you'd like more information on Data for Impact, you can see our website and social media pages. So today's webinar, as I mentioned, is on the EN Mini tools. Our June webinar will be on the Research and Evaluation Capacity Assessment Tool and Resource Package, which is a toolkit to assess and grow country capacity for rigorous research and evaluation of health programs. We also have a webinar series on integration in global health monitoring and learning. One session remains in that will be in, I believe, July. It's to be determined. Recordings of the previous webinars in the series, as well as other D4I webinars and webinar series, can be found on the D4I website, which you have here at the bottom of the screen, and will be, when these slides are sent out to you, you'll have that link. So I will now pass it over to Gabby to talk about today's webinar. And thanks once again to everyone for joining us. Gabby.
Thanks, Jessica. Good morning, good afternoon, and good evening. My name is Gabby Escudero, and I'm the Deputy Director for Data for Impact. I warmly welcome and thank all of you for your participation in today's event. During today's webinar, members of the EN Birth 2 team, comprised of the London School of Hygiene and Tropical Medicine.
Go to the Bluetooth menu on your smartphone and select it from the list.
Can you all hear me? Yeah. Hopefully. So during today's webinar, members of the EN Birth 2 team, comprised of the London School of Hygiene and Tropical Medicine, the International Center for Diarrheal Disease Research, Bangladesh, Ifukara Health Institute in Tanzania, and Data for Impact, will demonstrate the EN Mini tools and share findings from their application in Bangladesh and Tanzania. Following the presentation, Professor Joy Lon, co-director of the Maternal, Adolescent, Reproductive, and Child Health March Center at the London School of Hygiene and Tropical Medicine, will lead a roundtable discussion among a distinguished group of newborn, maternal, measurement, and routine health information experts on the EN Mini tools. USAID has supported the second phase of the EN Birth 2 study and the development of the EN Mini tools, with the USAID Tanzania mission supporting the work in Tanzania. We are very grateful for their support. We are also very fortunate to have welcome remarks from Dr. Barbara Rollins, Senior Implementation Research Advisor at USAID's Bureau for Global Health, Office of Maternal, Child Health and Nutrition, Research and Policy Division. Over to you, Barbara.
Thanks so much, Gabby. It's my pleasure to welcome you all to the webinar on behalf of USAID. The EN Mini tools that will be shared today are an important new resource that will really have the potential to help improve newborn-related content of national health management information systems, help to align the data elements in those systems with globally recommended indicators, improve the quality of the data needed to calculate those indicators, and promote use of those data for making key decisions. The EN Mini tools build on the findings from the EN Birth Indicator Validation Study and the PRISM assessment tools, which were created by USAID's Measure Evaluation Project, which have been widely used. I would like to take this opportunity to thank the collaborative research group that created the EN Mini tools, I would like to recognize that this represents a tremendous amount of work. And we at USAID look forward to seeing the tools taken up and used by many countries in the future. And now I would like to turn it over to my colleague, Dr. Theo Lippeveld, to say a few words. Thank you.
Hi, everybody. I am Theo Lippeveld. I am a retired person, but formerly was working pretty much all my life on routine health information systems, mostly via GSI as my organization. And also I founded a NGO with several other people called RHINO, the Routine Health Information Network. So I'm a long-time defender of strong routine health information systems in support of health service delivery and programs. And in that sense, I really welcome, well, all of you, but certainly the new EN mini tools for the management of newborns in low and middle income countries. More than 30 years ago, public health managers realized that maternal and child health care needed strong routine health information systems for decision-making in maternal and child health services. And therefore, in collaboration with WHO, the USAID funded measure evaluation project developed a set of tools called the PRISM tools. PRISM stands for Performance of Routine Health Information System Management, and they were finalized based on a framework and a set of tools in the early 2000 years. And a strong performing routine health information system was defined as a system that's based on relevant indicators, obviously for service delivery and data collection instruments to measure service delivery quantity and quality. And then also the data that are produced by those systems are used by health managers and providers for decision-making in primary health care and more specifically in maternal and child health. And this second criteria, that data are used, is tremendously important and is maybe still the one that needs to be further worked on. Now, the EN mini tools, they use that PRISM framework, but specifically to measure routine health information systems for newborns and stillbirth indicators. Because as you all know, neonatal health is a priority area in many developing countries. So it is expected by all of us that this EN mini tools can contribute to support neonatal health programs in low and middle income countries. Thank you very much. And again, welcome to this fantastically organized seminar, for which I thank all the people that were involved. Bye now.
Thank you so much, Theo, and thank you, Barbara, for your wonderful opening remarks. We're so grateful to have you with us today. So it's my great pleasure now to hand it over to Dr. Louise Tina Day from the London School of Hygiene and Tropical Medicine and the rest of the EN Birth 2 team. On to you. Thank you.
Thank you very much. And thank you to everyone for coming today to the webinar. As we've said before, please do post your introduction in the Zoom chat and any questions in the Zoom question and answer. The EN Mini tool stands for the Every Newborn Measurement Improvement for Newborn and Stillbirth Indicators. And this is a product of the EN Birth 2 study team. Colleagues' names are shown on this slide, and many of whom will be presenting today. The aim of the Every Newborn Action Plan is to end preventable stillbirths and newborn deaths. Milestone 7 is data for action to strengthen country use of routine data for coverage and quality of care to reach the ambitious newborn mortality target in the Sustainable Development Goals. Only 8 years remains. This table shows the 18 indicators prioritized for routine health information systems from the ENAP 2021 progress report. Data gaps remain both for outcomes and coverage and quality of care. There are questions about data quality. and as we've already heard about data use. And the EN Mini tools have been designed to help close that gap. In the SCORE 2020 report, low birth weight prevalence was the indicator that was assessed for newborn data. Among 133 countries, only 74% were reporting low birth weight prevalence from routine data nationally, only 51% subnationally, and disaggregated by sex, only 25% of those countries. But we need data at the right level of the data pyramid, at the right level of the system, to be able to accelerate progress for newborns and stillbirths. So the EN Mini tools have been designed to guide priority actions to improve availability, use, and quality of newborn and stillbirth indicators in routine health information systems. And I'm going to pass now to my colleague Josephine, who'll tell you more about these tools.
Thanks, Luis. Hello, my name is Josephine from Ifakara Health Institute, Tanzania. Newborn care core indicators shown in the gold in the center of the data pyramid are vital to data to guide the action and track progress. Different measurement sources contribute to core indicators, including surveys such as DHS and MICS, civil registration and vital statistics, and increasingly health service data. ENMIN tools are designed to contribute to optimizing routine health information systems data that can be used to review progress and performance and enable data use for policy and actions for newborns and stillbirths. ENMIN tools focus on aggregated newborn data from health facilities used for subnational, national, and global monitoring. An ENMIN assessment collects data from all professionals who record, report, analyze, and use newborn data. The process can strengthen the communication between health workers, HMIS, MNE professionals, and newborn RMSAH managers and policymakers. The ENMIN tools can guide priority actions to improve availability, quality, and use of newborn indicators in routine health information systems. The tools reinforce the dual focus needed to simultaneously strengthen use of data and improving data quality, and facilitate standardized data as recommended in the global guidance. ENMIN use and improved tools are adaptations of PRISM tools designed by Measure Evaluations. The MAP tool is a novel design. We are now going to tell you more about the 7 tools. Thank you. Over to you, Luis.
Thank you. The EMINI tools focus on the core indicators prioritized by the ENAP Every Newborn Action Plan, shown in orange on this slide. But the tools are also flexible for national prioritization and also aspirational indicators that are to come. A previous study, the Every Newborn Birth Indicators Research Tracking in Hospitals, measured validity of register source data. And as this conceptual framework for the EMBirth 2 study shows, we were interested in the data flow and feedback going up the data pyramid, and that's where the EN Mini tools focus. The tools are available on the Data for Impact website, and we'll paste the URL in the chat right now. I'm going to pass to Kim.
Thanks, Luis. So the first tool in the EN Mini set of tools is for mapping newborn data. This tool is designed to help you find the routine newborn data that's already in your system and can be used now to track progress, and to identify routine data gaps for what you need and what you want to measure, and also to reduce the measurement burden, especially for frontline health workers. The tools data collection portion is Excel-based and includes 5 worksheets, including instructions, background, definitions, data collection, and troubleshooting. So you can see here the Excel definitions page, and this includes key newborn specific and newborn related indicators, which will be included in the tool for mapping to indicators found in the country's HMIS. The definitions can be updated by the user to match the latest recommendations or any country-specific differences from global recommendations, and additional indicators of interest can be added to this list by the user. The data collection can be done in two phases. So first, the user records the document level, document title, and indicators or data elements that are found in their HMIS. And second, the user determines if each data element or indicator is specific or related to the newborn and if it maps to the list of globally recommended indicators shown on the previous slide. After the data is collected in the Excel mapping tool, it can be uploaded and the user can instantly generate and download a report analyzing the data they collected. And the report is generated as a Word document with background information and results that are directly from the data that were uploaded. And this document can then be edited with any country-specific or setting-specific details. And we'll be showing examples of the outputs from this pilot from this report in the pilot presentation. So how long does the EN-Mini mapping tool take? It depends on how many registers and forms are mapped. In this pilot, it took 1 to 2 days, and the reporting is available in minutes. So now we'll look more at the tools under improve newborn data quality and use newborn data for decisions.
Thanks, Kim. These next tools reinforce that the dual focus is needed to both strengthen use of data, even if it's not perfect, with ongoing efforts to improve newborn data quality. These tools are called the EN-Mini PRISM tools, because as you heard earlier from Theo, they were adaptations of PRISM designed by Measure Evaluation. PRISM tools have been used in more than 40 countries to comprehensively assess RHIS performance. The EN-Mini PRISM adaptation uses priority core, newborn and stillbirth indicators. And additionally, we've added some user-friendly components, including automated analysis. As you can see in the conceptual framework, the PRISM conceptual framework, there are important technical determinants, organizational determinants, and behavioral determinants in order to achieve high-quality data for use. I'm going to pass to Hattie now.
Thanks. So to ensure data collection is simple and in line with the existing PRISM tools, the EN-Mini PRISM tools have been set up for data entry on the digital platform Survey CTO. Data can be collected using smartphones or tablets, and the ready-to-use forms are available for download on the EN-Mini website. Survey CTO is a software platform based on ODK or Open Data Kit. It has GDPR compliant security features, and here you can see how the data entry forms look in practice. So now let's move around to use. The EN-Mini tools assess newborn data use for decision-making via the 4 tools shown here. They will help users to discover who's using the routine newborn data in the health system, to find out which newborn data are in electronic data systems, and to learn what additional data are needed by users to promote targeted investment for newborns. This is an example case study from the EN-Mini PRISM Tool 6, which assesses organizational and behavioral factors that can impact on data collection and quality. For this question, respondents are asked to look at the graph and work through real examples of data use for decision making. For example, describing the birth weight mix for neonatal deaths in this hospital, calculating the overall neonatal mortality rate, and based on these data, prioritizing a birth weight group for improving quality of care. There are also small group exercises for respondents to solve together as shown here. You can see these provide a great opportunity for participants to model data use within interdisciplinary teams as is needed in practice.
The final 2 tools are around improving newborn data quality. So these check the existing data quality, look for feedback mechanisms, whether they're effective, and to explore what resources are needed to further improve data quality. The tools are populated with a smaller set of core indicators from the list we showed previously. And this is the reason why those indicators were selected, and typically the care level, the facility level that those interventions occur, and the prevalence. Both improve and use data are analyzed through the EN-Mini PRISM analysis tool. This was, has been designed in partnership with Barb Nittel from D4I. The data from the Survey CTO platform is uploaded into this macro-enabled Excel, which generates detailed tables, heat map summary tables, as well as report-ready figures. And we'll show you examples of these analyses later in this presentation. How long do the EN Mini PRISM tools take? So to do all of them from 1 to 6, it depends on the size of the facility and the district office that's being assessed. But for our pilot study together in Bangladesh and Tanzania, at a secondary tertiary hospital, it took 1 to 2 days, and at a primary facility between half and 1 day. To upload the data, to do the analysis, generate the tables and figures takes less than 1 hour. I'm now going to pass to my colleagues in Tanzania.
Yeah, thanks, Louise. We are now going to show you some of the results from ENMIN tools assessment in Tanzania. So starting with a few highlights from MAP newborn data, ENMIN 2.0 reports. So from section 2, here is the table for Tanzania. The heat map showed availability for indicator, numerator, denominator, and full indicators at the national level in Tanzania, DHIS2. In Tanzania, as you can see, most of the newborn or stillbirth indicators are already in DHIS2. But neonatal sepsis has a numerator and denominator available, but the indicator needs to be manually calculated. Preterm birth and antenatal corticosteroids are not yet in DHIS2. From section 3, we can see data availability from all locations where the data elements has the exact definition. The report encourages the reader to see where both the numerator and denominators are available from the same source. Section 5 can be used to understand documentation burden. The data elements needed for core indicators measurements are shown in blue. Other data elements are shown in orange. In Tanzania, all levels, this is our DHIS2 summary form registers, only 29% of the data elements are needed for core or optional indicator measurements. The figure on this slide shows the register level, and most of the data elements are in orange, not needed for newborn, core or optional indicator measurements. So we can consider reducing register data elements so that we can reduce the burden on healthcare workers, and then have them more time to care for patients instead of collecting data elements which are not needed for core indicator measurements. Thank you. Now I'm passing to my colleague, Jacqueline.
Good afternoon, everyone. My name is Jacqueline Minja. I will share the ENMIN PRISM Tool 1 to 6 Tanzanian pilot. Our location was in Tanga region. We sampled both the district office and 16 facilities that provide inpatient newborn health services. These include 2 hospitals and 14 health centers and dispensary chosen by simple random sampling. The respondents were all professionals involved in newborn still data recording, reporting, analysis, and data use. We trained our data collector over 5 days for this pilot. This slide shows the overview figure of our ENMIN PRISM tool pilot assessment in Tanzania using the PRISM conceptual model. We will show you some of the results today, and more details are available in our report, which you can find on our ENMIN website. First, for use newborn data, here are some of the results for organizational factor, RHIS process, and the data being used for decision for newborns. We found some strengths at the district level, but facility level data use was limited. We interviewed 47 respondents in 16 health facilities and found promotion of information culture ranged from 44 to 77%. Measure of RHIS task for health workers was 19 to 70%. There was a quite large competence gaps, such as calculating indicators and interpreting data correctly. Now turning to improve newborn data, for our data quality assessment for the denominators needed for indicator measurement, it showed at the district level, we found excellent data accuracy for data entry onto the HIS from summary reports. But at the bottom of the pyramid, the source register data was only 88%. To improve newborn data quality, looking at the organizational factor, behavior factor, and existing data quality improvement efforts, we found these factors to improve data quality were stronger at the district than facility. Notably, motivation among facility staff to perform RHIS task was extremely low at 6%. We identify a large gap in RHIS training. At the facility level, less than a half of health workers had received any RHIS training. I'm passing now to my colleague, Donat.
Thank you, Jackie. My name is Donald Shamba, and I'm a member of the ENBERT2 team at IHI in Tanzania, Ifakara Health Institute in Tanzania. And here I'm going to share with you some a summary of the findings from the pilot study that Jacqueline just presented. So in summary, first we, in our EN-Mini tools pilot assessment in Tanzania, we identified the strong performance to recognize. From MAP newborn data, we found most newborn data elements, indicators, were already in DHIS2. And for improved newborn data quality, we found that there is an evidence of organizational factor for RHIS at district office. And also there's a good completeness summary reports for newborn indicator denominators. And also there is an accurate data entry in electronic RHIS from summary reports. And for use newborn data decision, we found that there's an analysis, visualization of newborn and the stillbirth data is happening at the district level, and also use of information for key performance targets is also done at a district level. And for the gaps, so we also found gaps and the need for focused action. In summary, for MAP newborn data, we found there is a need to streamline RHIS processes to reduce data burden for duplication. And for improve newborn data quality, we found that there is a need to value frontline health facility staff collecting data to overcome the very low motivation. And also we found that there's an opportunity to train health facility staff in RHIS competencies to ensure feedback reports reach health facility, and also to improve supervisory actionable discussion. And for use, we found that for use of newborn data for decision, we found that there is a need to improve data or information culture in health facilities, and also to strengthen newborn data analysis, reports, and visualizations at the health facility level. Now, handing over to a colleague in Bangladesh. Thank you.
Thank you, Donald. Hello and welcome, everyone. This is Shima Mazabin. Along with Dr. Hassan, I'll be presenting the findings of EN-Mini assessment in Bangladesh. The EN-Mini assessment was conducted in Kushtia district, Bangladesh. The district has one district hospital, 5 Upazila health complexes, and 1 maternal and Child Welfare Center, which were selected. At the primary level healthcare, we had 5 union subcenters, 4 UHN FWCs, and 5 community clinics, which in total 21 facilities were selected. And the data were collected between September to November 2021. Next. First, I will present the findings of mapping newborn data. Here, I will try to answer 2 main questions. Those are what level of facilities document newborn data in Bangladesh, and where do they document this data? To answer the first question, I will briefly explain the public health system of Bangladesh. In Bangladesh, there are 2 main implementing agencies, Directorate General of Health Services and Directorate General of Family Planning, DGHS and DGFP. On the left side, we see the type of facilities through which DGHS is catering the health services. And on the right side, we see the DGFP facilities, the type of facilities through which DGFP is catering the health services from central to local level. The green icon of pregnant woman and newborn shows the type of facilities providing maternal and newborn health services, whereas the orange one means some of these type of facilities are providing maternal and newborn health services. Now let's see the documentation, how this documentation happen in this type of facilities. DGHS facilities collect and report their data into District Health Information System, DHIS2, whereas the DGFP facilities collect and report their data into, they used to, the earlier server was service statistics. Currently, electronic management information system, or EMIS, has been introduced to many districts. However, in Kushtia district, most of the facilities are still uploading their data into service statistics. Next. In the DGHS facilities, we identified relevant maternal and newborn register and reporting forms, and those were mapped to see the availability of ENAP indicators. Similarly, for DGFP side, number of, next. DGFP side also, we identified number of MNH register and reports which were mapped. Now let's look at the availability of ENAP indicators in all mapped reporting forms of DGHS and DGFP. For most of the ENAP indicators, numerator exists in the reporting forms except newborn with documented birth weight and newborn treated for sepsis infection. Newborn treated for sepsis infection indicator was adapted for Bangladesh context, and both the numerator and denominator exist in the reporting forms for the outpatient department. The only denominator which is not available is for KMC initiation for premature babies. Moving forward, looking more closely at the data elements of register and reports, we can here see that both the register and reports have more percentage of other indicator in orange than the WHO or nationally recommended core or optional indicators in blue. It shows that a lot of data elements are collected and reported which are not related to the shown ENAP indicators but may be important for other programs or indicators. Next. Now I'll present the status of data use, focusing on the following questions. What is the data use at district or facility level? What is the competence level of the health workers for RHIS tasks? And what is the data culture for data use at the facility level? Next. To answer the first question, here we can see the answers are presented at the district and facility level. Overall data use is much better at the district level. For example, the RHIS processes like data visualization and data use to produce analytical reports is done at all district offices. However, only around 1/3 of the facilities do it. Next. Here we can see the competence level of the health worker for RHIS task. There is huge gap between self-reported confidence and self-assessed competence of the respondents. For example, we can see that 91% of the respondents were confident that they can calculate percentage or rate for an indicator, but only 16% of them were able to do so during the assessment. Next. Regarding the promotion of information culture, we can see that most of the variables are at high percentage. However, less than half of the facilities reported that evidence-based decision-making culture exists in the facilities. Next. Third and last section is improving newborn data. Here we will answer two questions. What factors can improve newborn data and how important supervision is in improving data quality? To answer what factors are affecting routine data quality, we can see that some factors are better at district level and some are better at the facility level. For example, designated staff to check the data quality is present at all district levels. However, only a little more than half of the facilities have a designated staff to check the data quality. Then, if we look at supervision quality score, it is 63% at the facility level, whereas it's only 21% at the district level. As supervision visits are considered as one of the key elements to improve data quality, let's look at it more closely. Less than 1/3 of the district office has a schedule for RHIS visits, and copies of supervision guidelines exist at the district level offices. If we look at the facility level, more than 90% of the facilities has a supervision visit in the last 3 months. However, only less than half of them reported that data quality was checked during the supervision visits. Now I will hand over to Dr. Ehsan.
Thank you, Shima. So we had 3 big questions, and I'll try to summarize that based on Shima's presentation. What are the big picture findings? The first one is about the mapping of newborn data, and the 3 big questions were that, are we collecting data to report on the ENAP indicators? That's on your left. And if we are doing so, that are we collecting the data at all levels? And if we're doing so, are we also collecting data that we actually do not need? The answer to those questions are yes, we are collecting data with which we will be able to report most of the ENAP indicators. And we are also collecting the data at different levels of the health facilities with some gaps. However, the striking point is that we are also collecting a lot of data that we don't need to report on the ENAP indicators, national strategies, or any of the global policies and commitments. So this is a big finding, that we are collecting a lot of data that we do not need. On your right, these are the bigger questions around decision-making, data use, and we wanted to conceptualize these questions into 3 big items. The first one is that, are we using this data for our program monitoring? The answer is yes, but mostly at a national and district level. The second question was that, okay, if you're using this data for program monitoring, are we taking any decision based on that data, based on this program monitoring? And here is a bigger lab, that from the policy level to the district level to the sub-district level to the health facility level, who are generating that data, there is a major gap regarding making and taking decisions for improving the quality of care. And then we wanted to understand that what is the issue regarding the competency of different levels of the policymakers, program managers, and healthcare providers. And Shima has rightly mentioned that the issue is regarding the competency. Next. So how do you improve that? Any improvement starts with identifying the root cause of the problem. And from our exploration, I think our root cause are of 2 types. The first one is about the provision. We identified that it's about the lack of knowledge, it's about the lack of capacity. So we have to really focus on there. The second root cause is about the supervision, that we have to make data use, data provision, data generation, and monitor the quality as a part of the routine program. So the issue is about the supervision checklist. And one of the most important findings that Shima has shared today is that even when our program managers and the supervisors give feedback on their data quality, give feedback on the supervisory visit, they do not record their documentation and the feedback. How can we expect the healthcare providers will gonna document everything when, as supervisors, as managers, we don't document our own feedback? Having said that, the way forward is to invest in the capacity, invest in the policy, and make data as a part of routine practice rather than just as a tool to monitor and supervise. Thank you.
Thanks very much. So to summarize, the members of the ENBirth 2 study team today have shared with you the EN Mini tools. These are flexible tools designed for country contextualization with a focus on sub-national and source facility data. They build on the strength of the PRISM conceptual framework and also include a novel mapping tool. The tools are designed to be user-friendly and nimble with direct digital data collection and automated reporting. Increasingly, routine health information system data is needed and being used for core indicators for newborns and stillbirths. And the EN Mini tools can strengthen that discussion between all the many stakeholders needing and using data to guide priority actions to improve the availability and strengthen strengthen global standard measurement. We've deliberately aligned the EN-Mini tools with the SCORE essential interventions for strengthening country health system data capacity. We've designed the EN-Mini tools also to strengthen ENAP milestone 7, data for action, because we all need data so that every newborn can survive and thrive. We'd like to thank USAID very much for funding the EN-Birth 2 study, and I'm now going to pass to Professor Joy.
Good afternoon, good evening, good morning, everybody. And I just want to start by recognizing what a fantastic group of both participants, speakers, and panelists are involved here. My name's Joy Lawn. I'm speaking to you from Tanzania, and it's my privilege to be your host for the second part of this very exciting webinar. So in the first half, we have heard about the EN-Mini tools. Map, use, improve. We've heard this amazing synthesis of what this means in both Bangladesh and in Tanzania, with really rich content. So in this second half, we have two dynamic and exciting components. The first is we have people from all over the world and different expertise to give you some angles to stimulate you to dip more into these tools. And then secondly, we want to hear from all the participants. So I can see we've got questions coming in thick and fast now. Please do post your questions. We'd love to hear from you, and we'll have time to discuss this later. So I want to start by jumping into this wonderful panel. And for each of the panelists, I'll give a brief introduction, their question, and they will give us their wisdom. So we're going to start at global level. So for indicators and measurement, the World Health Organization, WHO, have a very important mandate in setting norms and standards for indicators, for numerators, for denominators. And so much work going on in this area. And within that, who better to speak to than Dr. Alison Moran? So she's the lead for maternal health at the Department of MNCAH and Aging. But she's also somebody with a very deep and long experience in routine health information, and actually also in Bangladesh, and the lead for the Ending Preventable Maternal Mortality and Every Newborn Metrics groups. So Alison, you have many different global indicator groups and many things going on. How do these tools link to that, and other ways that the EN-Mini tools could particularly help us to improve comparability of global data? Over to you.
Right. Thank you so much, Joy. And thanks very much for the fabulous presentation and for including me today in the panel. As Joy said, I think at GLOBE we have a variety of different tools that can be used to strengthen measurement. And as Louise mentioned, I think the EN-Mini tools are really designed to be consistent with the SCORE principles. And if you're not familiar with SCORE, that's a WHO and partner-led initiative to really strengthen strategies and interventions for strengthening health information systems. So it's fabulous that they're structured within that framework. And then on the maternal, specifically around maternal and newborn, there are a lot of efforts going on to really standardize and harmonize indicator definitions. And so we have this advisory group called the Monitor Group that's looking at almost finished developing an online indicator toolkit, which will help colleagues prioritize which indicators they should collect through the routine data systems, as well as through other data collection platforms like household surveys and others. And so we see the EN-Mini tools as an essential element of that package moving forward, because it allows you to take the indicators that you would prioritize for newborn health and for reducing stillbirths. And then, as we just learned, think about how to map what elements are already being collected and really focus on improving the quality of those data, as well as reducing the burden on the healthcare providers to improve decision-making and use of that information moving forward. So we're really excited to continue to work with this team to think about how we can support rolling out the ENMINI in different countries to help them operationalize these tools to strengthen their systems so that we can really improve national and global level tracking of the Every Newborn Action Plan and ending preventable maternal mortality coverage and mortality targets, so that we can really accelerate progress to achieve the targets in the SDGs as well as the Every Newborn Action Plan. So thank you very much for the opportunity to be part of this panel. Look forward to hearing from other panelists as well. Back over to you, Joy.
Thank you so much, Alison, and thank you for all that you do in a current environment. It's really appreciated. So as we leap forward, we're going to move from Geneva to Bangladesh and to Dhaka, and a very warm welcome to Dr. Shariful Islam, and he's the Assistant Director at the Health Services Directorate in Bangladesh. And he's also been a wonderful, consistent leader for both the newborn program and the child program. And we're just so honored for you to take the time to join us today. And thank you for all that you do in Bangladesh, and also for your great advice during the first phase of the ENBirth trial. So in Bangladesh, you have really been a leader in many ways for electronic data systems at national level. But maybe because you started earlier than others, you've also ended up with many people putting many indicators into your system, including also for newborn health. Are there ways you think these tools could help to reduce the burden, maybe to remove some indicators, or ways that you think the tools can help you in Bangladesh? Thank you.
Thank you, Professor Joy Lon. Thank you for inviting me in this seminar. Assalamu alaikum and good afternoon to all. This is Dr. Mohammad Shariful Islam from Bangladesh. The National Newborn Health Program and the IMC in Bangladesh have co-led the activities of ENBirth study with ICDDRB in Bangladesh. We developed the ENMINI tools after several consultative workshops and regular assessment. These tools have shown the potential to critically assess the data availability, data use, data quality at all tiers of facilities. In Bangladesh, the routine health information system is complex, where different programs have introduced different registers, reporting system, and forms, increasing the documentation burden, which again reduces the data quality. We have the findings of the ENMINI tools, and we'll use it to plan and to take necessary steps to improve the newborn data. Already, we have developed an app for data reporting system, and we oriented the district managers and other health complex managers throughout the country, and we are encouraging them to use these apps and sending data and developing a monitoring system from the district level and sub-district level data. So we are working in this data management system, and we are trying to improve this data management system and also data quality. I think ICRB will help us, and the ENMINI tools will help us to improve this data quality system. Thank you.
Thank you so much, and such an important point, not just which data we collect, but do they have high quality and can we use them? So we're going to now jump across the world from Bangladesh and back to Tanzania. So in Tanzania, we are going to meet the dynamic Dr. Felix Bondala. He's the head of newborn and child health in the Ministry of Health, and is leading very ambitious scale up for small and sick newborn care across Tanzania. So honored to be partnering with you and Nest on this, Dr. Bundala. So Dr. Bundala, as Tanzania have been a key lead, both in the EN birth validation study, but also in this work. The EN mini tools, can you maybe give us some insights on how they could help you to address gaps? Bangladesh have talked about how it could maybe help them reduce load, but are there key indicators that you would like to see and that you think the EN mini tools could help you to assess and bring into your system?
Okay, thank you so much for this invitation. Based to the questions, I think thank you for the organizers and the supporters for conducting the EN birth validation and EN mean assessment, of which basically have been a potential resource towards what we can use in improving our systems. As Josephine mentioned, that using the EMEN assessment, it has helped us to understand the situation in terms of that what do we have in terms of indicators to collect, and what do we miss in that angle that as she mentioned, that we have realized that there is a number of indicators available in the DHS2. But you will need to improve the quality of it and making them more realistic, but also looking to the sum of indicators who will be missing, so that to improve our documents. You have mentioned it very well, Professor Joy, that for the past 3 years and the coming next 3 years, the Tanzania struggling or making effort to attain the national targets and also the 2030 targets to reduce newborn deaths. We are basically cooperating with various partners, including IHI through the NEST 360 and the other partners, to make sure that we have an adequate or many neonatal units in our health facilities, at least 80%, or district hospitals having the neonatal units. And that will mean admitting more newborns in our facilities. And if that's the case, we need to have a prepared system of documenting our newborns, where we have the HMS tools for documenting the small, the sick newborns admitted, but also even the monitoring tools. And from there, we need to make sure that they are entered in the DHS2, and like the few indicators also be available in the dashboard. So basically this EMEN assessment is going to be the potential resource as we are making different stakeholders meeting to look at seeing what is available, what is missing, and how we can make better the HMS tools, particularly for newborn and child health in this country. Thank you so much.
Thank you, Dr. Bundala, and thank you for your leadership also in bringing many partners together to harmonize these indicators, so people are using not just the indicators, but the same registers and forms, and also counting admissions to the newborn ward. So staying in Tanzania, we're going to move from Dr. Bundala to, we're moving to Dakar. We're leaping across the sea and back again. So we're leaping to Dr. Shams Al-Arifin, who is really internationally famous for his research around data in Bangladesh and beyond. And really leads a fantastic research consortium in ICDDRB. And Shams, I want to personally thank you for all that you have done in this area, and also really excited to be here with some of your team following up the EN birth babies who are now going to be 4 or 5 and entering school. So Shams has
and you never know, they are going to soon be teenagers and adults.
Yeah, we're moved from birth to smiling, and then we've gone from smiling to reaching school, and we were joking one day we will be surly for teenagers. But Shams, you know, you have really been important in your own team and beyond in raising up analytical leadership. You know, getting better data is good, improving data quality is good, but raising up that leadership to use data. Are there suggestions that you can make, and also ways you think these tools can help us to do that? Over to you, Shams.
Thanks, Joy. Briefly, and I agree with you. I think improving data use, you know, has many aspects of it. One of the things, easy ones, is making data more accessible and etc. But at some point, you need the skills to analyze the data in a way that is useful. And you know, and so often do you see situations where, you know, those skills tends to be limited or lacking. So I think there has to be investment needs in countries like ours, where people across the board who are working with data have the skills to analyze data. And also they're working within, for example, you know, in teams where, you know, there are others who can provide guidance and the leadership within each facilities, within its districts, to look at the data, interpret it, and focus on areas where maybe something looks a bit weird and maybe it needs to be checked up, etc. So I think that ability to identify misleading data, it doesn't come easy. You have to spend a lot of time looking at data, using data, analyzing data, and you know, this ability to identify misleading data and errors in the data, you know, is something that is a real need. And I think that, and by and large, I think all of that means that you do need to continue looking and analyzing data and making it available, having other people look at the data and criticize you, and you know, you not being defensive about it. So one of the things that we, you know, within ICDIB, we do make a lot of investments in providing these skills and the leadership skills, analytical leadership skills among our staff. And as you said, it's a very good team. But we also need this to happen among other partners, the government and elsewhere. These are not very difficult skills. And I know from our own experience that working with other partners across TACA, that there is a real need for providing the guidance and skills and the training to other people so that they can analyze the data themselves. And it has been very rewarding at our end. So I think this investment has to happen. And I think I'll urge you that in addition to the tools that we have, which we hope will provide good data, we continue working in the country in terms of making sure that the leadership for analysis is there. Thank you.
Thank you, Shams. And this is so important. You know, as clinicians, we focus a lot on competency for care of the mother or the newborn, but also we need competency for data, being able to smell bad data that's unsafe. Because if we have data that we don't recognize is maybe only capturing 20% of the deaths, or it's capturing them selectively in urban areas, we can actually make dangerous decisions for policy. So thank you, Shams. And I ask for all of us that we find ways to lift the data capacity and invest more in data capacity for all, for both the people at the front line and the collectors and users of this data, to all the way up. So now we are indeed moving from Bangladesh and back to Tanzania. This is a beautiful team, and you can see we have two-way interaction all the time. So we're now back into Tanzania with the fantastic Dr. Honorati Masanja. So Honorati has a really eminent career as a statistician. He's also the Chief Executive Director of the Ifakara Health Institute. And Honorati, our question to you today is, you know, we can talk about having the data, but if that data does not have high quality, it's really not going to serve the purpose we need? How can we improve the data quality, and how can these tools help us to do that? Over to you.
Good morning, good afternoon. Thank you very much, Joy, for having me to discuss about data quality issues in this webinar. Basically, data quality at the top of HMIS is dependent on the quality of data, and this starts at the source, which is the health facility, where health workers meet patients or mothers and children who come for various routine health services. It is important that there is also a feedback loop and data use, because if there is no feedback or data use, then whatever we are trying to do will be useless. So very, very important feedback, but also data use. So in Tanzania, we did this assessment, and it showed us that we really need to focus on the data quality and the data use by starting at the facility, which is, as I say, is the source where the data is being generated, and also strengthen these frontline health workers who have a major role in the routine health information system. And if they are capacitated, then they'll be motivated to provide high quality care and high quality data. So we think that EN mini tools, they can strengthen the dialogue between the health and the data professionals, because there definitely needs to be a dialogue between these two cadres. We all know that data management and data quality requires certain knowledge and certain skill sets, which unfortunately we do not do a lot of investment in this. We know that there's a lot of investment that is done in clinical skills. We think it's high time that the government also now needs to invest in data capacity by training more data clerks and data managers in the newborn wards and in the labor ward, because data in these two areas in the facilities is really not as good as elsewhere. If we are able to invest in that, then we think the mothers and newborn will be looked after by clinicians who are experts in the areas, and the data will be looked by data experts who are experts in the areas. And as I've said earlier, we need to strengthen the dialogue, and I think the EN mini tools will be able to facilitate that. So for me, I think data quality, dialogue, data use is really key. Thank you.
Asante. So data dialogue. I think that's the quote of today. So the dialogue between those who are collecting, but also that they get to understand and use, and those who are capacitated to use the data also then are going to be motivated to collect it better. Thank you. So we're now moving from our seesaw across the world, Bangladesh, Tanzania, Bangladesh, to move back to those who really lead on the use and improvement of data. So Dr. Tariq Kazim is a senior M&E technical advisor at John Snow International, and he's also famed for his expertise in quality of care, but also data quality. And Tariq, our question to you today is particularly around the history of the PRISM tools, which have had such a rich heritage. We heard from Teo earlier on, who was a key architect of those. And one of the strengths of those that we've really learned a lot about is the behavioral and organizational factors. It's not just having the right forms and the hardware, but that software of the behavioral and organizational factors. So from your experience, can you maybe give us some tips on that broader behavior and organizational factors in improving data quality and systems? Over to you.
Thank you, Professor Joy. Yes, as you can understand, that it's not only the selection of indicators or the type of forms, but also this organizational and behavioral determinants are equally important for improving the performance of a routine health information system. And the use of these PRISM tools kind of dig out the issues around those determinants. And I'm very happy to see that the PRISM tools have been adopted for EN Mini. One of the latest adaptations also were done in Cambodia and Kyrgyzstan in 2021 to assess the capacity of the staff, MNE staff. And interestingly, what we find that, like you have been presenting, I've been listening to this presentation, and we see that there is a lot of confidence in doing data analysis, but when you put them in scales, they cannot do that. Whereas in Cambodia, they find that there is a lot of skill. They know about it, but they don't have the confidence to really do it. And this is something to do with the organizational support or enabling environment. And I see one of the questions by Mohan also relates to that, it's not only training, which is the answer, it's also creating the enabling environment that will encourage the people, the staff at every level to use that data and make decisions. So it relates to the decision-making space or empowering them. And this is how the PRISM tools can identify those areas. In addition to, for example, we have seen in other countries like multiple registers being used, so they don't believe on any one of them because these don't talk to each other, these reporting systems, and so forth. So I guess, focusing on this behavioral and organizational determinants through this EN-Mini will be very helpful in improving the newborn health information system. Thank you.
Thank you, Tariq. This is so rich and really critical that we look at this enabling environment as well. We need the piece of paper, we need the electronics, but we also need to enable that. And an important point that the skills and confidence can mismatch either way. So we're now going to move up into the electronic system. So when we think of electronic data systems in, now many low and middle income countries around the world, the system that people are using or adapting from is DHIS2, has really helped to lead a transformation in electronic data systems around the world. And in that, they're always being asked for more indicators. So I'd like to pass over to Dr. Johan Ivar Seibo, and he's in a fantastic Norwegian national outfit because it's a holiday there. So we're particularly grateful to you for joining. And maybe you can give us your perspective from DHIS2 on how these tools or the principles that they use could be applied in DHIS2. Over to you.
Thank you, Joy, and hello, everyone. Yeah. You mentioned, how we are often approached to support in adding more data to systems running DHIS2, and we refer to this as the global burden of data collection, and it is indeed a challenge. And to echo some previous speakers, I think I very much agree that first you need to capacitate staff to use information. You need to delegate responsibility to, and create all these organizational and maybe social structures before we talk about adding more data element and indicators. And I think these tools bring that perspective, more of a everything is connected to everything perspective that shows how these different things are linked. And as intuitive as this may sound, I think unfortunately such a perspective is still needed to counter, specifically from my perspective, an emphasis on technology, which is often seen as a silver bullet. You can make it easy to collect more data. That doesn't mean we should do that. It also needed to counter an emphasis on data collection and data quality, completeness, and timeliness, because the EN-Mini tools has such a big emphasis on data use or information use. And I think that's a key point, that information use is not the end product of this system and system design. It should be the starting point that determines what kinds of structures you need, what kind of data you need to collect, etc. Thank you.
Thank you, Johan. This is so important. We design our data systems the wrong way around sometimes, asking what data could we collect rather than what are the few pieces we really need, and then reverse engineering. So important. Thank you. And thank you to you and DHIS too for the wonderful global good that you provide. So I'm now going to move from beautiful country of Norway to the beautiful country of Italy. And we have Dr. Marzio Lazzarini. She is the director of the WHO Collaborating Center in Berlo and known to many of us, a wonderful, warm, smart, and collaborative leader with a lot of practical applications in data. And Marzia is the PI of a new and exciting grant called Impulse, funded by the Chesi Foundation, which will be working in a number of very variable contexts. So Marzia, maybe you could give us some thoughts on how ENMini tools maybe could be adapted or used across the different contexts that you'll be working in Impulse. Over to you.
Thanks, Troy. Maybe first of all, I really want to echo the voice of others in congratulating with you, Louise, and all the team in making available these tools. And I have to say that personally, I had the opportunity of using this tool in the last weeks while we were piloting our data collection through Impulse. And I have to say that I've become a real and sincere supporter of the ENMini tools. And I really believe that they can be a turning point in improving newborn data quality in different settings. And the reason for me to believe that is that, first of all, they provide a very comprehensive assessment of newborn data availability, quality, but also they are looking at root causes at the different level of the health system. And secondly, I very much appreciate this automatic reporting that can provide in real time a comprehensive but synthetic picture of what is going on in different settings. And I very much like the format, the heat map, which really flag out actionable gaps in data quality. So I really believe these can be extremely helpful for decision makers, but also very powerful for driving data quality improvement. So this is just something that I wanted to say. And in regards to the Impulse study, yeah, we are delighted to announce that the ENMini tools will be used in Africa through this new project, which is called Impulse, which is an acronym of Improving Quality and Use of Newborn Indicators. So as already mentioned, Impulse is kindly funded by the Chesi Foundation, and it's a collaboration between us, the WHO Collaborating Center in Maternal Child Health in Italy, and the London School, the Joy teams, and Louise as well as a co-PI. And we are using as platform and implementing agency QAM Doctor with Africa, which is the largest Italian NGO, working in several countries in Africa and having established country office and everything. And through this project, we are going to use the tools in 12 different regions in 4 different countries. Most of these regions are humanitarian settings or hard to reach area. And specifically in Central African Republic, we are working in Bangui and Beverati. In Ethiopia, we are going to have data from the conflict zones, plus Oromia, Sao Tome and Gambela. In Uganda, we're going to work in West Nile, which, as you know, it's a refugees area, but also in Karamoja and Lango. And also we're going to work in hard to reach disadvantaged area in Tanzania, such as Shinyanga and Simini. And also, and interestingly, we will use these tools in different types of hospitals. So we will have the public, but also the private, and also the faith-based. together with facility with different volume of work. And this, of course, will allow comparison among facilities, but also identifying local champions that can really lead the change at national level. I also believe that this is a great opportunity for the EN tools because it will be a practical opportunity of translating the tools in several languages. We are considering French, Amharic, and Swahili at the moment. And also it will be an opportunity to further diffuse the tools among local stakeholders. We are working in dialogue with WHO and UNICEF, but also with local representative from Ministry of Health. And we have, for example, a wonderful representation from Ethiopia, Tanzania, and Uganda, really a large representation from Ministry of Health. We are working together with local academia, Makerere in Uganda, together, of course, with Ifakara. We are working with scientific society, such as the Ethiopian Pediatric Scientific Society, professional organization, such as the African Newborn Association, and I've seen some members also joining in this workshop. We also hope to reach and to involve practically in the parents group. So really it will be an opportunity to not only get feedback from national and international stakeholders, but also to drive, to help, to support in this process, possibly to embed such tools in really in routine use. Also, we aim at further documenting and identifying most effective methods of implementation in the hand of local teams, and possibly at developing complementary tools, such as tools specifically looking at case notes. So overall, I have to say that I'm delighted to be part of this movement, bringing forward the EN tools. And I'm also looking forward for learning together and for sharing back to this large community the new findings. And thanks a lot.
Thank you, Mazia. Really so exciting, and we welcome you to share as you go along. And really exciting to hear also about translation en français and also Kiswahili. And to note that these tools and the EN Mini tools are being put on the newborntoolkit.org, which will also have lots of different translations as a global public good. So we're going to move forward now to the fantastic Dr. Nina Chadka. So Nina has been really an expert in newborn health and also newborn health measurement and use of data for a couple of decades, and also a wonderful friend for a couple of decades. Thank you, Nina. And is now the leader in Momentum for the newborn health aspects. So Nina, maybe you could speak to us about some of the opportunities, both in Momentum and Save the Children, for use of these EN Mini tools. Where could they be helpful? Over to you.
Thank you, Joy. And it's been a real pleasure working together in the past couple of decades that we've been together for newborn health. So thank you, Joy, for that question. Momentum is a suite of innovative awards funded by USAID to improve voluntary family planning, maternal and newborn and child health services around the world. And the suite of projects are together working in around 30 low middle income countries across Asia and Africa. Now, one key component of newborn care for every country we have the privilege of working with is data systems. And at Momentum, we are really committed to improving routine HMIs and the robust and effective use of data through quality improvement and through enhancing competencies for data, as mentioned before. So we see this, the EN Mini tools is a godsend for us right now. We see huge potential for it to help country teams apply an evidence-based process, not just for current newborn indicators, but also for new indicators, and to improve quality and use of data. Hence, I feel like this, with the countries that we are currently working with, we have these tools which are tested that we can share with ministries of health partners for them to utilize and draw upon. So on behalf of the countries that we serve and support, and on behalf of the Momentum team, we are really grateful to have this resource. We will be in touch with all of you to seek support and help all through this process in the coming years too. So thank you.
Nina, thank you. Such a warm and thoughtful expert on many fronts. So the anchor of this panel, last and definitely not least, is the equally fabulous Dr. Tedbab Degafi. So Tedbab has really been a key person in Ethiopia for newborn health, and then in UNICEF, and then wonderful leadership from New York. And you know, one of the really impressive things, Tedbab, has been the momentum around tracking for the every newborn, what needs to be done. And one of the things you always highlight to us is how red the pages are for measuring newborn care indicators in routine HMIS. Could you maybe speak to us about a way forward with that and how these tools could help many countries? Over to you.
Thank you, Joy, for organizing this wonderful, excuse me, panel, and also for being such an excellent leader for the last 2 decades in advancing the newborn agenda. And it's so good to see dear colleagues who have been part of this journey. And thank you also for inviting me to be part of this panel. As we all know, the Every Newborn Action Plan calls, urgent action to avert the annual burden of 4.4 million newborn deaths and stillbirths, and and regarding that time, we are just halfway through the SDG era. So there is urgent need to accelerate progress. As we have seen from the recent progress of the Every Newborn Action Plan, where close to 93 countries show major gap for almost all countries with data in a routine HMIS system. As Joy mentioned, almost all the indicators, the major indicators that we need to measure are marked as red, showing a huge gap. Now with the ENMini tools being validated and made available, we can collect data. And the validation also has shown us that the data can be reliable, and the countries can definitely use this data as soon as possible, as soon as it is available, which is now. And also I would like to point out existing opportunities for the uptake of these indicators in National Health Management Information System and improve data quantity and quality. The ENMini tools are now online, free, and designed with direct data entry and automated analysis, which is really key that providers at point of care level and also at the district level are much needed. The results generated also show us where we can invest at and use the right strategy at the right time. We do have the right indicators, and these are more quickly being used to improve care and to meet our collective targets that we are all committed to measure and support countries. I would like to use this opportunity to again reiterate UNICEF's commitment to ensure these data are used to the betterment of maternal newborn health. With the presence in over 190 countries, and with the commitment in prioritization, the health and safety of mothers and children, UNICEF remains a committed partner with you all. And along with the Every Newborn Action Plan partners, we are keen to work together and help countries assess and improve their data indicators. And again, I would like to thank each and every one of you for your heart and committed work for the last 2 decades to bring us to this level. And thank you, and over to you, Joy.
Tedbab, that's just such a powerful note for us to come towards the end of this panel, that all of us have a role to play. We can all do something, both to improve and to use the data. So at this point, we were going to take all your questions. I have to salute the team. So the EN Mini team, they may be called Mini, but they're definitely maxi for the amount of work and also maxi for the speed of answering questions. So it looks like there have been 11 questions open live answered, and there aren't any open live. So what I would like to do is just open up to the panelists again. For the panelists, and I would like to ask everybody, participants and panelists, this question. So we have this urgent action to reach an SDG by 2030 for maternal deaths, for stillbirths, for newborn deaths. And to do that by 2025, we must change things within our routine data systems. So even in the foreseeable future, the next couple of years, by 2025, are there things that you think we can do and ways that the EN Mini tools could help you to change that? So please feel free to post in the chat your ideas to increase the number of indicators on key items, to make them comparable, to reduce data load on people, to improve data capacity, ways that you think we can change in the foreseeable future. And we really welcome you as partners going forward. These tools are being put out as a global good by the team. We welcome you to adapt them, to translate them, to use them, to make additions, to take things out of them, and to let us know. So please do feel free to do that and to come back to the team and make suggestions. And what I'm going to do now, I think, with this call to action and people's ideas of actions, is then to first of all thank you as participants for joining, for your time, for taking forward this work. I want to especially thank all the team, really remarkable team who have worked together and started during the pandemic and still able to keep going and to deliver. So thank you. And I particularly want to flag Louise, who's been just exceptional in bringing that forward. And thanking the team from Bangladesh, from Nepal, D4I, and also to acknowledge SIF for funding in the first part, and for many partners for your collaborative network around this work. And then I'm going to pass back to the D4I leaders, and particularly to Gabby, with great thanks to all of you, and back to you, Gabby.
Thank you so much, Professor Joy. And I just want to echo Joy's thanks to all of you, to the panelists, to the opening speakers, as well as my utmost thanks to the EN Birth 2 study team. I hope that you have all been inspired to use, promote the EN Mini tools, which can guide priority actions to improve the availability, use, and quality of newborn indicators and routine health information systems. You will all be receiving a link to the recording of this webinar and the slides as well following today's webinar. A reminder too that the EN Mini tools are available on the Data for Impact website, and we'll be adding other tools such as the Tanzania and Bangladesh EN Mini PRISM country reports in the coming weeks. So please do visit the website. It's been put here in the chat a few times. And so we look forward to hearing from you. And on behalf of D4I and the EN Birth team, sincere thanks for your participation today. With that, I'll end the webinar. Thank you so much and goodbye.